We're going to talk about polyps now, and really polyps are what it's all about with prevention of colonic cancer. We know that colonic cancer almost always starts as a polyp. The interesting thing about colonic cancer, and the actual amazing thing about colonic cancer, is that this is the one cancer that we can actually prevent. So most screening tests for cancer pick up the cancer when it already is a cancer. So let's say you're screening for prostate cancer. You find a blood test which is positive, you look at the prostate, and there you see a cancer. The screening is helpful because you pick up the cancer in a very early stage when it's much more amenable to treatment. With colonic cancer, it actually is different because you pick up the potential colonic cancer, which is the polyp, when it isn't yet a cancer. So this is a benign polyp. This polyp, if we leave it for some years, it depends on the nature of the polyp, 1, 2, 3 or 4 years, it will develop into a bigger polyp, and eventually it can develop or will develop into a cancer. So the great thing about colonoscopy and colon prevention and colon cancer prevention is that we can see this is the beginning of a colon cancer even before it's a cancer. There you can see the colonoscope, there you can see a snare coming out, 1, 2, 3, 4, 5 polyps. We often see polyps, and then you take out the polyp, we send the polyp away to the pathologist, and they look at it, and then they can say how sort of bad the polyp is. Are there any evidence? Are there any cells which are malignant? Is there anything to be worried about? If you see multiple polyps, you try and take them all out. Usually we can succeed. Sometimes patients have many dozens of polyps. In fact, I've taken out hundreds of polyps in one single patient. If you've got lots of polyps, 10 or more, we'll repeat the colonoscopy fairly quickly. If it's a small polyp like this, easy to remove, we just snip it off, take it away and send it to our pathology colleagues. Normally that comes back as a benign polyp. There are basically two types of polyps that we see. It's a little bit technical. Tubular adenoma, this is almost certainly a tubular adenoma. That's the most common polyp. There's another kind of polyp called a sessile serrated polyp, which is a flat, quite difficult to see polyp. Also with a malignant potential. All these polyps have malignant potential. It really depends on the size of the polyp. If you see a polyp, which you sometimes do, which is 5 or 6 centimeters big, we can still remove those polyps with a snare. The way we do that is we inject underneath the polyp, we use a big snare, and we use current that cuts through the snare. Obviously, the bigger the polyp, the more dangerous it is. These little polyps are easy to remove. The risk is fairly minimal. You do get sometimes a little bit of bleeding, very low risk of perforation. If you do get a very big polyp, it's obviously much more challenging. It takes a lot more time, and there's a much bigger risk of perforation or bleeding after taking the polyp out. But this really is what it's all about. If you have polyps, if you see polyps, we remove the polyps, and then the risk of colonic cancer goes down to virtually zero. Sometimes you can miss polyps, and sometimes you can miss colonic cancer, particularly if the preparation isn't optimal. Sometimes it's difficult to complete the colonoscopy. Patients who've had previous surgery, hysterectomy surgery particularly, or inflammation or infection of the bowel, sometimes makes it very difficult. But 99.9% of patients we can get right through the colon. We can check the colon and make sure there aren't any polyps and there's no risk for cancer. So the colonoscopy is a fantastic screening procedure. When do you start doing colonoscopy? That's quite a difficult question to answer. In principle, my feeling is that at the age of 50, you should really get a colonoscopy. Most of the countries in the developed world have got screening programs. So you do blood tests, the fecal occult blood test. You do a sample. We look in the sample and see if there's any blood. If there's any blood, it indicates that there's a cause for bleeding. Very often this could be a polyp. Very often it could be a hemorrhoid or a little cut in the anus. But sometimes we pick up that this is a cancer. So the screening test, the initial screening test, is looking for blood in the bowel action. A very sensitive test, but not very specific. When you get a positive bowel screening test, obviously we need to do a colonoscopy. The colonoscopy is the definitive treatment for this. The other important indication for a colonoscopy is if you have a strong family history of colonic cancer. And some patients are very proactive as far as their health is concerned, and they want to do colonoscopy just to make sure there's nothing in their colon. This is actually a very sensible approach because 5% of the general population will develop colonic cancer. It's one of the most common and definitely the most avoidable cancer. Whenever I read of famous people dying of colonic cancer, which you often do because it's a very common cancer, I feel very upset, and I always think if only they'd come for a colonoscopy, they would not have this cancer. So colonoscopy is really a fantastic way of preventing colonic cancer. Normal people, or the normal population, a 5% incidence of colonic cancer. If you've got one relative who has got colonic cancer or has previous polyps, your chance of getting colonic cancer goes up to about 10 or 15%. If you've got 2 or 3 relatives with colonic cancer, the chances go up to about 20 or 25%. So what do you do, for instance, if your mother had colonic cancer, if you've got a strong family history? Speak to your doctor and then we'll do the colonoscopy earlier. Let's say your mother developed colonic cancer at the age of 50, then you do the colonoscopy on yourself 15 to 20 years prior to this. So there's very often, with a family history, if the gene is present, the colonic cancer occurs at an earlier age. So we're always quite careful, and we actually treat patients with a strong family history according to guidelines with regular and earlier colonoscopies. If we see lots and lots of polyps, we follow up obviously quicker. If I see a really big polyp and we take it off, we'll follow up in 3 to 6 months. If we see more than 10 polyps, we will follow up in 1 year. If we just take out 1 or 2 polyps, then we can repeat the colonoscopy in 5 years. If you've got a predilection to form polyps, then even if we take out the polyps, the new polyps will form, and we've got to keep a very close eye on you. So this polyp is in the descending colon. So remember, the colon looks like that, going all the way down. So that polyp is around about in that area. That's about the size of the polyp. So this polyp is probably about 12 to 13 millimeters in size. The colonoscope is about 12 millimeters in diameter. So that would qualify as quite a small polyp. But you can get massive polyps. So if a polyp's 1 or 2 or 3 centimeters in size, that would qualify as a bigger polyp. But sometimes you get polyps that are absolutely enormous, and they sort of cover most of the bowel. There's a very high chance of malignancy in these big polyps, but they can normally be removed. So we carefully evaluate the large polyp, then we plan for a long colonoscopy. I always bring patients back for the repeat removal of the large polyp because there's a definite risk of bleeding, probably, you know, about a 2 to 3% chance of bleeding, and there's a much higher risk of perforation. The risk of perforation with a colonoscopy is normally 1 in 5,000 to 1 in 7,000. That obviously depends on the experience of the person doing the procedure. But if you take out big polyps and you do this very complex interventional type colonoscopy, the chance of complications is obviously much higher. So the bigger the polyp, the more dangerous it is. The bigger the polyp, the higher the risk of cancer. Sometimes with the very big polyps, we take them out and we actually do find cancer cells in them. The pathologists are very, very helpful with this. You do get a polyp and then they'll sometimes report that this is a high-grade polyp. Those polyps are virtually a cancer. So if you do see a high-grade polyp and you take it out in time, you definitely know that within 6 months to a year, this would have become malignant.